I'm going to begin with a few slides about the Collaboratory and what it does and upcoming events before I introduce our guest speaker, Dr. Genevieve Melton-Meaux. And I will preview my introduction by saying I am a charter member of her fan club, so you're going to get a totally unbiased and objective introduction. You should fully believe every word I'm going to say. Okay, let me just say a few things about the Collaboratory and today's session. First of all, it is being recorded and will be available soon on our YouTube channel. So you will have perpetual access to the proceedings here today. As I said, the session's being recorded, and for anyone on Zoom, please keep your mics muted, and there will be time for audience question and answer, and you are very much a part of our audience. If you enter your questions in the chat, we will address them along with the questions that come from those who are gathered here in person today and enjoying a lunch from Jerusalem Garden. So if you like the food from Jerusalem Garden, you may want to be here in person for our next event, which I'll talk about in a moment. CME credit is available for this session, and this QR code is the key to claiming CME credit using activity code 92825. So this year's theme of the Collaboratory series is around articulating the value proposition of the learning health system. Our speakers are speaking to different aspects of that, as those of you who have been to earlier events in the series know. I am one of the three co-chairs of the Collaboratory and the Collaboratory series. My other co-chairs are Dr. Ed Hurwitz, wave to the multitudes, Ed, and Alexandra Vinson, who is online or in the air. I'm not exactly sure in what order things are going to occur. There are three learning objectives for the series around understanding the attributes of a learning health system, utilize the understanding to incorporate data into research and improving care, and into developing all-important infrastructure for learning health systems, and to be able to discuss the development and maintenance of learning health systems. Today's presentation is around building a regional learning health system hub from Dr. Melton-Meaux. We are in the introductions now, and the presentation will begin momentarily. We'll have time for question and answer, and we'll wrap up around 12:30. I'm sure you will have lots of questions and lots of comments to make, and we look forward to a very interesting discussion after her presentation. I'll launch into my introduction in a second. And let me just go ahead here and just see. Oh, these are your slides. Okay. You don't want me to give your talk, do you? No, I don't think so. Okay. I just want to mention, in case we don't get to it later, next month we have another extremely distinguished visitor, and this is Dr. Leora Horowitz from NYU, who is a leading proponent, as is Dr. Melton-Meaux, of learning health systems, and this is going to be a great 1-2 doubleheader, having the two of them here in rapid succession. You'll hear a lot of similarities and what they have to say, but you'll also hear some interesting differences. So to introduce Dr. Melton-Meaux, she's the McKnight Presidential Endowed Professor of Surgery and Health Informatics, Senior Associate Dean in Health Informatics and Data Science, the Director of the Center for Learning Health System Sciences. And if you ever got email from her, you'd see there are other things on her on her signature line that are not here, but trust me, she does somehow other things in addition to this, all at the University of Minnesota Medical School. She was an undergraduate at Washington University in St. Louis, did medical school and surgical training at Johns Hopkins, then went to Columbia University to get a PhD in biomedical informatics, and from there went, this is right, to the University of Minnesota, plus or minus, where she is today. Her clinical interests include colorectal cancer, inflammatory bowel disease, minimally invasive techniques, and individualized care. Her work spans surgical informatics, clinical natural language processing, improving EHR documentation, evaluating technology solutions and practice, advancing learning health systems to generate real-world evidence and improve patient and community health. She also does things like she's going to be doing today, helping us think about, based on her experience, our own journey toward becoming a learning health system. And we are so delighted that you're here, and please welcome, and we look forward to your talk. Thank you.
All right, can you hear me now? Okay. All right. So thank you all, Chuck, Ed, Alexandra, who's traveling, and Gretchen. I'm so appreciative to be here. And I will say up front, this is probably the first time I've presented to a group that is focused on learning health systems. I often present to health systems, clinical groups, clinical translational groups, but this is a real pleasure. I'm just going to start by saying no disclosures, and I may talk about some technology products along the way, but I'm not endorsing any. So just to start off, greetings from the Twin Cities. It's a place that is near and dear to me, and even more so now. I've been there for 17 years, and will say as well, we're not going to talk in any great depth, but I'm probably on my 4th avatar. So if you'd like to talk about, career pathing and what that looks like, and just how, the world leads you in different ways, I'm more than happy to talk about that. And I will talk a bit about our story for how we formed a learning health system initiative at the University of Minnesota, and really for the state of Minnesota. And that's, the story I'll tell today. But if you'd like to talk more about career pathing, happy to do so. So this audience does not need to really know the motivation, but this is the driving motivation. This horrible leaky faucet. You always hear the issue of the 17-year odyssey, most of which never makes it there. And we really have totally underinvested in it. What's the point if it never gets to people? And, that last mile, it's a bunch of different things, right? We need infrastructure to support it. We need people to believe in it. It needs to work. What does that mean today in healthcare delivery? What does that mean today where consumerism is really front and center, and people feel like they don't have systems that care for them? That's a really tough place to be, but that's our opportunity. That is our opportunity. So, there's many reasons that this has occurred, right? We talk about that lag, and we talk about anybody that's in clinical operations, and, I spend about half my time in clinical operations. These things don't sync up. You know, the ivory tower and clinical operations and everything that needs to be done, and there's no money, these really do need to be built and done a bit differently. And, you know, to be frank, our educational programs and our research programs don't necessarily incentivize it, and we need to think about it differently. So it's great. We are all people that believe in this solution, which is a learning health system. I think there are many definitions out there. I often quote some that Chuck has been front and center in developing, but it really is this cycle between knowledge and evidence, practice to data, and an underlying culture and environment where these things can happen together. That's a tall order, right? And that is very aspirational, and it does mean truly building a different animal where that ivory tower and clinical operations somehow have an overlap and a Venn, and we come to understand each other in a different way. Another definition from AHRQ, which I hope will soon be active again, where we bring these things together and integrate them and put it into practice in a cycle that keeps going. I'm going to talk about our origin story to start, and really how a set of circumstances came together that allowed learning health systems to be supported through the University of Minnesota and our clinical partners. It started with Tim Beebe, who I'm incredibly grateful for, a health services researcher that was based at Mayo that came to the University of Minnesota. And he had the vision. He had been at the Kern Center, one of the founders, where they were, you know, starting to bring academics, clinical care, innovation together. And there was a call for proposals to train folks in learning health systems. So that was our first seed. There was a field trip. It's very coincidental. It was to NYU to visit Leora Horowitz. She was so generous with ideas in the types of infrastructure she had set up. And there were many things that we learned and even copied as we did this work. Up front is our chief academic officer, who came on, who was actually the person that said, we got to go there. Brad Benson. Next is our chief quality officer, myself in the role at the time of chief analytics and care innovation officer at the time for our health system as a bridger, and then Tim Beebe. There were investments that the medical school was doing. The health system, we had a CEO that believed in being a data-driven organization, and also digital transformation. And then we had COVID hit. So those ingredients came together in a really specific way. And there was the ability for us to get leaders to listen and say, why don't we do this? Why don't we do this together? So we founded our center. It is a center that is a deliberate collaboration between the medical school and the School of Public Health. I will say we're completely interdisciplinary, even though we're claimed by those two schools. We have folks from the School of Nursing, the Institute for Health Informatics, folks from computer science and engineering, and others. But we decided we were going to focus on the state of Minnesota, really build, if we could, a distinguished program and think about how we could be a hub and a resource across the state. Here's how we're set up, and it has gone through a couple of different iterations, but again, we are focused on that cycle, evidence to practice, thinking about implementation, and then this huge bucket of real world data, digital health, AI. I'll talk about building a learning community and a bunch of infrastructure that's associated with all these things. I do think, you know, when I look around the country, I do think the evidence synthesis thing is a little bit unique. I don't think I've seen many learning health systems that have deliberately brought that into the program. And then many of the other pieces I think you'll see elsewhere. I do think that implementation and evaluation sciences probably is underestimated. underemphasized in here, and one that we're continuing to really double down on. Just some faces and names. I think a couple notes. Most of the folks here are either in the School of Medicine or the School of Public Health. As an example, our pragmatic trials lead is Joe Koopmeiners, who leads biostatistics, as a for instance. Mary Butler, as well as a health services in the Department of Health Services Research. And then several of the others are data scientists, clinicians, et cetera. We have a monthly seminar similar to you. Several folks actually from Michigan. Rachel's here. Julia, who used to be here. I'll show Karen Deep in a moment. Chuck has spoken with us. So really have tried to bring folks with different perspectives to try to share. And then I'm going to talk a bit about both our meeting as well as our training program. So similar to you, we are now a part of the P30 Embedded Learning Health Systems program. Our program is set up across 5 clinical partners, and I'll talk about that in a bit. We have our scholars that are set up much more like K scholars. They're independent scientists that are earlier in their career, fellows that are in some place during their training. We've had some PhD students, mostly residents though, or folks that are in the VA quality program. And interesting, our clinical informatics fellowship, they all participate as fellows in our learning health system program. And now we're starting to build out these smaller, more intensive programs in the form of internships as well as other shorter programs. So again, this started with the K-12 and now is the P30. Does give you more flexibility. You can set up some infrastructure. If you look at the partners that we had before, they're similar, although Mayo Clinic is no longer one of our partners. And then we've added Health Partners, Essentia, and I'll talk a bit about kind of where they're located and what type of coverage that ends up bringing us. So Fairview is the main academic partner for our health system with the University of Minnesota Medical Center as part of it. And you can see sort of geographically our reach. This is a good way you can kind of see it within the state of Minnesota. But we have some of our sites that are even up near the Iron Range. And then within the city or the metropolitan area of Minneapolis, we have both the Minneapolis VA, Hennepin Healthcare, which is our safety net. You can see some of the different sites throughout the Hennepin County. And then we have Health Partners more in central Minnesota. And then Essentia, which is in northern Minnesota, going over to Wisconsin and North Dakota. So it gives you kind of the idea of where this hits us geographically. The K-12 program had a total of 14 scholars, 6 cohorts, and then we have a new cohort starting this year, and that will be another 8 scholars that we are looking forward to welcoming in. And then the P30, again, is a lot more of folks that are in training at different stages. Just to note, a couple different things. One is that folks really do come from very interdisciplinary areas. In all cases, we put together an individualized development plan. There are some core didactics, usually on Fridays, that folks do together. But very much this is to build the competency that folks need for where they need to go in their career. So you can see as well, like we have some folks, somebody that's a physical therapist, a social worker. We've had a pharmacist come through, several PhDs, nurses as well. So really a wide variety of folks that are getting trained and very much also building on programs that are already in place. So we've made a deliberate attempt to talk to folks that are leading T32s or K programs as a whole, so we can get a twofer. So if somebody in their training might benefit from it, we are a bridge to the work that they may be able to do. The other piece around learning that has been really helpful, in addition to the seminar series that we have, is our annual conference. So this year will be our 4th year. This last year, our 3rd annual conference, you'll see another 2 Michigan folks in one way or another. Karen Deep, who's now at UCSD, who's their Chief AI Officer, and then Amy Kilborn, who's at the Michigan VA. And actually has a national position as well. And so, the other thing to note is, and I'll talk a bit about our partnership with the Minnesota EHR Consortium at the end, but really, again, folks from health systems throughout the state, every single health system has participated, and, starting to also build capacity. So this past year, we had workshops, and we're going to add on to that because that was a very successful model. Okay, so I'm going to step through each of the units just to give you a flavor of the type of work. We can stop. I'll stop at the end of each to maybe talk and get questions that you may have. So the evidence synthesis program, again, we have an APC that has been funded for, I think, close to 30 years now through AHRQ. If you think about how evidence practice tends to work, there's sort of this traditional thing, right? You respond to a task order, you do society guidelines, a systematic review. Well, what does evidence look like in the practice? And what does it look like if you need to think about it being a much more agile thing? And that's where we've really focused. This idea of a living guideline, I'll give an example of that. Also, how can, a health system engage quickly with the evidence cycle? So here's some examples. At Fairview, for instance, we have something called care mats. This is the way that we are thinking about caring for patients as a whole. So you can think of enhanced recovery after surgery, or what is the evidence-based way that we're going to care for somebody with diabetes in primary care. And they often have evidence questions, right? So we did the state of the sepsis evidence. We had been implementing a bundle for a period of time. Is there anything new? Should we be doing it differently? We had some non-agreement between guidelines of what the radiologists believe and primary care believes. Let's have a discussion about the evidence within the health system to say, okay, how are we going to address that at the front line so that clinicians and patients are not confused? So those are some of the things that we do. The other thing that this has provided is a way to create an evidence community. And we have several of these where, it's a pod of folks that have a set of questions that they want to ask using the evidence. This is an example, happens to be from my division. But a younger faculty member, Paolo Goffredo, and then our division chief, Wolfgang Gertner, came together and said, we want to ask questions together. And everybody else that you see outside of Mary and Bronwyn, the 2 folks that are leading the evidence work, these are all trainees. And many questions that were asked as a group, and publications, and really building a wonderful community together. This has also been helpful for garnering grants. There's often now the ask to do evidence-based work. This happens to be with the FDA around opioid prescribing and pain management after surgery, but then the ability to disseminate and implement these guidelines. As another example, the idea of a living guideline. How do you represent it? How do you continue to iterate on it? How do you find the new evidence as it changes? This happens to be really around a pragmatic trial that's interoperable, which we could talk a bit about. But the third aim, as you see, is really based on evidence. And how do we do that better and think about a living guideline? Okay, I'm going to take a pause. That was really about evidence, but if folks have any like burning questions, or I can save them to the end. Okay. All right, so I'm going to talk a bit about pragmatic trials, our peer unit, and then kind of go from there. So we call this rapid eval. This was one that we really learned a lot from the NYU group. And the way this tends to work is this is both a bottom up as well as potentially even a top down approach. But typically we do a call for proposals, typically twice a year. We also get ideas sometimes from the practice. So I don't know, the chief of the Heart and Vascular Service Line might come to us and say, you know, we are really interested in something. We had one time, one of our pragmatic trials, the CEO said, I'm really interested in how we do our appointment reminders. What's the wording? What's the timing? How do we test this in practice? But again, we do have this call for proposals because we think it's really important that folks from throughout the organization, whether it is a faculty member, a student or trainee, a frontline nurse, can ask questions and be able to be engaged in the work. So I'll give some examples in a moment. The other complementary group is peer, which is really around our implementation science and how do we evaluate any of these interventions. And this, I think, has been one that we only formed really over the past 2 years, and has been really, in many ways, the bedrock, even though we didn't actually call it a unit. But we realize in so many cases, we need to know why it worked, why it didn't work, and what are the factors to set it up in a way that that we're doing it in a way that may be most successful along the way. So this has been, I think, arm in arm with any of the evaluations that we've done. This group, you know, probably has talked a lot about this, but, you know, it really is nice to frame it up in, you know, we've got quality improvement done all the time. We test a lot of things. We may or may not truly get numbers at the end of it. And it's often not set up in a way that is thought about from the beginning as a research question. We have classic clinical research, right? That typical randomized controlled trial. And it's often devoid of the practice, right? Is this practical even, you know? And it is often quite separate from clinical care and how it's being thought about, designed, and everything in between. And then in that middle is really that pragmatic place where these two things are coming together. When we're thinking about a lot of the work that we're doing for rapid eval, a lot of this stuff around, can it be done quickly? Are we going to have the power that we need? Might it need to be adapted along the way? We've had a couple that have had to be adapted. And at the end, we still do want to have something that is something that can be disseminated and shared and learned from. So in all cases, there is a publication, at least one, often multiple as a result. So this gives you kind of a flavor of some of the projects that we have funded or supported along the way. A couple notes, we've had multiple trainees, like Sagar Deshpande is a surgical resident. We had a pharmacy resident or fellow that also had one as well. But it does range a whole variety of topics. And in all cases, for the most part, there is some sort of technology intervention that helps to facilitate the trial that occurs. So just to note that. I love this quote. This is from one of the folks that participated and led one of the pragmatic trials. You know, it's like, what is this going to be like? What we've really tried to do as part of this is be a facilitator and a set of infrastructure and a system behind doing this work. A lot of the folks that come up with these ideas, these maybe in some cases, these are R01 type researchers or folks that are on the academic track, but many are in the clinical scholar track. You know, most of their time is spent in clinical care. Arjun happens to be someone that is on the track to being, you know, an academic physician. But, you know, just to say, you know, the way we've designed this is really to help folks to really be excited about this idea of research and how do we build this into clinical care in a different way. So, you know, read through it, but it is this idea of the entire way we're helping to facilitate the work and think about how to design it, think about how to implement it. This has also made us more competitive for extramural funding. This is one example. This is a UG3, UH3 through NIA with digital nudges around the surgical encounter and increasing the rates of advanced care planning. We're blinded to the results. We are about 1.5 years into the 3-center trial. What we can tell you is it looks pretty good. That's all I'm going to say from where we can see, but we are blinded. I'll shift now to talk a bit about this large area of informatics, really around data, digital health, AI, which I think really should be thought about as not only essential, but an amazing catalyst and opportunity right now. So, okay. And I'll motivate it a bit around AI, because you can't go to any talk today without hearing about AI at some point, right? And I do think, good or bad, many health systems are looking at AI as an answer to the financial woes that they are facing right now. You know, if you look at how inflation is going, how payment models are going, and that reimbursement that is happening today and what the costs look like, it doesn't add up. So if you're going to like deal with that cost curve, there needs to be ways that you can change your staffing pattern in very specific ways. You know, if you think about the call center, what will the future call center look like? Or you think about some of the work that a nurse does, maybe it's around the post-op phone calls or the pre-op phone calls, or, you know, those types of things where much of it could be potentially done by an agent or something else in a different way with less staffing. This is different, and I think everybody knows this. You've heard it, but it really is a convergence right now of many things, and the world is going to look a lot different. You know, how quickly, I can't tell you exactly, but it's quicker than it has been. Let's just say that, and it's hard to keep up right now. And you know, this graph is a really good one because it does show how quickly performance of some of these models and some of these tasks, how much better it is, or as good as human baseline. And that is where we need to at least be. Many people think it has to be perfect, but it just needs to be better than us. It is, and I am a true believer in this because I am an informatician. This is really part of digital transformation as a whole, and it does take all these things coming together in very specific ways. And if we think about what digital transformation is, you all know this, but our lives have changed in incredibly marked ways because of what's going on societally. Think about your retail experience. I'm not saying it's better. I'm not saying it's worse, but it has changed, right? Brick and mortar. I do DoorDash, Uber, Amazon. You know, these digital native companies have changed how we consume things, right? And this is happening in all our lives in really significant ways. You know, what's happening as far as digital health, what's happening in healthcare, and how is that disruption happening? It's a little different, right? It has not been as quick, and that's probably a good thing, right? Because we need to have very high standards. We have to keep our patients safe. And, if you think about what happened with virtual care, well, it could have happened before, right? But it took like reimbursement and COVID and really significant things for that to happen. And, you can see it. We're being pushed more and more in that direction for it to happen with many AI solutions. But when you think about digital health disruption, and I'm an evangelist around this, it really is not just your AI and what it does. It is not just a piece of technology and what it does. It has to fit into that ecosystem, and it has to work in a workflow that is going to be highly integrated. So, it is that whole design aspect. And when you think about like the competencies that are needed, that all has to be put together in a really specific way. So just one more note here, as we thought about competencies that need to be in our learning health system, the one that we have our eyes on is design. And what does design need to look like as we continue to change? And this is an incredible accelerant right now for where we're going. So this slide just gives you a flavor for some of the pieces around informatics data, that type of thing. So I mentioned our interoperable work with CDS, a lot of work with OMOP, fire, smart on fire work. We've delved a little into CPG or clinical practice guidelines. And again, that ties back to the evidence work. A lot of work on, how do we build out our IT infrastructure to randomize, to be able to do clinical trials broadly. And then also, if you think about the care and feeding of data and you're going to do it with AI, what does that look like? How well does an interoperable decision support that's AI enabled, how does that work? And there's a lot that needs to still be built, but this is where it's all going. As we think about, we need solutions on top of our health information technology. We need to be able to have the data represented in a consistent way, whether it is at an Epic shop, a Cerner shop, or multiple Cerner shops, or whatever that might look like. And, there's a lot of pieces that need to be validated and done well. We've dug really deep into federated learning, have several collaboratives or several groups in our collaborative for doing this type of work. And then I'll talk a bit about some of the digital technology solutions. So it gives you a flavor. As part of our work, we do have a data core. It works very complementary with our CTSA. We use and leverage the infrastructure that's been built there, a secure data computing environment. But we had the idea of bridging very close to health system operations and also trying to provide a little bit more of a concierge service around data services. So this just gives you an example. Typically I say, I'd like some data. And I go and I try to get it. And then I spend, 4 months trying to get the data the way I need it. And then we can analyze and hopefully disseminate. What we've tried to do is build up a learning community around the data and really get deep in with the experts. So, at one point, I think we had close to 25 clinicians that were helping us to build out different data facets, right? If we can do it in an interoperable way, we will do that. But something like, how do you measure ambulation in the EHR, right? That's not going to necessarily be top of mind for your interoperable framework. And so because we've built out our data dictionary so well and have worked very deeply with different clinical groups, getting the data to them is much faster. We've also built out a lot more infrastructure as far as, what's your question? Can we help you get the IRB through quickly? So we've been able to sort of make that process a much easier thing. And, many of our clinicians, don't spend a lot of time doing research. So all the friction that you can take out of that process has been a really, really helpful thing. I'm going to talk about a couple of examples of digital technology solutions that we have worked on. So Mike Pitt is a pediatrician, pediatric hospitalist. John Sartori is in electrical engineering, and they came up with the idea of Q-Rounds, which is an app that does transparent rounding. It's really, really cool. And the app there's a patient-facing version, family-facing version, a version that the clinicians that are rounding, as well as the nurses that are at the bedside can use. This has ended up becoming a product. They are now in several hospitals and have been implemented in several hospital systems. And we really spent time helping them to both evaluate as well as figure out all the pieces of integrating their app into the EHR. Amazing experience as a whole. Some of the things that they thought about a lot were things like, how do we get the interpreter there? What do we do if somebody can't come to rounds? They could come virtually to rounds. How do we help people to anticipate when the clinician will come? Because if you're on the other side as a patient, you spend all day waiting for that patient, for the team to come, and you never know what to expect. So this addresses that need. It's a different example. This Sagar Deshpande, again, is a surgery resident. He had done some work at the Kennedy School and was very interested in behavioral health economics. And so we built out two different versions of nudging to help clinicians to help patients, wean from their opioids after surgery. So we are basically done now with a pragmatic trial. This was built, in this case, into Epic, and we randomized patients individually to getting one of two of the interventions versus no intervention. A different example of a program that started as a quality improvement project, and as part of it, now, not only have we evaluated it, but we're in the middle of doing a pragmatic trial to look at the duration of monitoring in which patients can be stopped earlier that have hypertensive disorders after pregnancy. So this program is a remote patient monitoring program. Patients that have given birth, that have postpartum hypertensive disorder are enrolled into it. Incredible patient satisfier. We decrease rates of readmission by 70%, and really an amazing, patient experience piece. So a couple things that we learned. The first is that after hours was an issue. So they were only available till 4 p.m, the nurses, and a couple more hours going to maybe like 7 o'clock, we thought would make a difference. And we also had an issue because it was only Monday through Friday. So right now we're in process of expanding to those after hours and a couple hours over the weekend. And we're going to expand to all the rural sites. So this was tested at one hospital, and now we're going to expand it to 5 hospitals. And then the trial that we're doing right now is, again, around the duration. Certain patients, because you're enrolled for I think 4 or 6 weeks. Some patients, their blood pressure is really normal, and you could probably stop them in about 2 weeks. So we're in process of doing that. The other part is readmission is not always failure. So the thing that we learned as well is, the patients that came in, we had some amazing early catches. Patients that would have had really bad outcomes, and they needed to come in, right? But we caught them early. So really great program. So the other thing that we've learned is this whole idea of design and thinking about, the human factors piece. So this is a patient safety learning lab that is embedded into our center. And Jenna Marquardt is an informaticist industrial engineer trained with Patty Brennan, who is a well-known informatician that ran the NLM, but really in this environment with interdisciplinary teams, nurses, industrial engineers. And what we're designing is how do you do safe recovery after surgery? And this really focuses on having patient engagement in the design of our interventions. I mentioned this idea of interoperable decision support, and this is a risk model that if you're in surgery, you may have heard of My Surgery Risk, but it tries to predict upfront if a patient is at high risk for one of like 8 or 9 outcomes that can occur after surgery. And this was built using OMOP, and it's like, okay, this is a great thing. Well, let's try it somewhere else. As it turns out, centers are not implementing OMOP very consistently. We had a nice conversation with David Hanover and Rachel Richardson right before this, and we were talking about how do you map your LOINC, right? And it can be very different. And so, this is the future, and we've got to get better at this. And we learned a lot in the process. We can talk about data science a lot, but just to say, this is an incredibly important component and will become even more so. Okay, so I'm going to end by talking a bit about some of these other partnerships. And really, it does encompass multiple entities. And I'll give a couple of examples. I'll give 3. So the first is Minnesota EHR Consortium, which is, I think, a really interesting thing that came out of COVID as well, right? So N3C, many of you may have heard of, is this collaboration, which is now being expanded, but many health systems in the process map their data to OMOP. And our state said, okay, let's leverage this and let's have an ongoing consortium that most of the major health systems, and in fact, in our state, all the health systems have their data mapped to OMOP. Okay. All the data stays locally. In most cases, all health systems will participate in a research question. But if for some reason, like we had an interesting one about differences that have occurred since January in the state of Minnesota, some of which are national, right? Medicaid funding, that type of thing, and some are very specific to what's been going on in Minnesota. Health systems could say, I don't want to participate if they chose. We all participated. But what we've done is partnered in different ways. So our evidence synthesis program has been sort of their evidence partner. And then as well, they hosted their first in-person meeting this past year. And hopefully we'll be able to continue that. CentraCare is a forming partnership, and we're extremely hopeful that this will be our next very, very close clinical partner. So University of Minnesota in the fall of this past year had their first medical school class. I think it's 25 students, and we have this affiliation agreement, and their vision is to be an academic health center. And the learning health system, we're very hopeful will be a catalyst for that. So you can see this site, their sites, again, it's middle Minnesota, a little bit north. It's a very rural-based community, and we're really excited. So we're gonna have a design session next week on Tuesday. So again, and we're having these conversations about, who's, we both have committed to some investment through the medical school and the center, as well as through CentraCare. And then who's going to do it? How will this be set up? How can we do this in a way where our infrastructure can help to accelerate their infrastructure? So those are the conversations. And then the final example is with our Translational Center for Resuscitative Trauma Care. And this is a statewide and actually national collaboration. There's some funding as well through the DoD, Uniform Health Services, but we have served as the honest broker of data and also their data management and analysis services. And that is also with the Department of Health through Minnesota. I actually have an abrupt ending. So So I took you through a whirlwind. I should have had something to ease us into the ending. But really, I mean, this has been, it's a journey, and we are, you know, on that, right? And in multiple places, in multiple areas, and many things that we need to grow. But very excited about the work that is occurring. One note, that MinPost thing sets it up well. We were recently named as what we call a medical discovery team, an MDT, which gives us state funding, and we'll have to go in with the next legislative funding session. So hopefully in 28, we will get that funding, but that is like what's ahead. So we're trying to think about, you know, how do we engage at the state level and really make ourselves very clear, like the asset that we think we're bringing value and demonstrating that to our representatives. So thank you. I'm happy to take questions and really appreciate the opportunity. Hey, Chuck.
A while ago, showed a slide that has 3 columns, and it had traditional research on one side, and QI on the other, and LHS people. So the other word in the middle. I assume the research in the left column was regulated under the IRB.
Yep.
And the research and the work in the right column may not be.
Yep.
What about the stuff in the center? How do you handle that?
Great question. So for folks online, Chuck asked the question about IRB and where does learning health system research fit? So we had a question about that. So we asked them to look at the evidence. So we have a paper that's actually, or a manuscript that is currently being reviewed. So it's all over the map in what we see nationally and locally. And actually, you should ask Leora this question next time or a month from now. They have been able to do things where most of the learning health system work is considered QI and really becomes exempt immediately. Ours has been somewhere in between. And in almost all cases, and there's an exception now because we're doing this trial with Hope BP, that needs actual consent. The majority just happens and it's been considered QI, or it's been considered in a way where informed consent is not needed. And we've had a couple where there needs to be some informational piece that at least it's not maybe consent, but there's some assent that the patient is aware or the provider is aware, I'm in a trial right now. Okay. So we've had all of those cases occur. The thing that we've tried to set up, knowing that sometimes things are less consistent and sometimes this doesn't fit in the one lane or the other, it's in that blur, is we've tried to set up a couple things. We have a very ongoing discussion directly with our IRB. We have an ongoing discussion with our research administration in the health system, and we get their endorsement around anything that is truly QI. And sometimes we even have the chief quality officer weigh in and say, this is QI. We send that letter with our IRB application. So it's very clear this was going to happen anyway. We are not causing additional risk. In fact, we're probably decreasing the risk because we're evaluating it. We're actually going to have numbers and we're going to know what worked or didn't work. So we've tried to set those things up. The other thing we're trying to do is with the IRB, we found there can be differences even between like the administrator who looks at it, because there's a lot of variability there too. So those relationships have been really important. And, you know, and then the last piece is trying to set up a relationship with our CTSI, which does a lot of work with clinical researchers as a whole. And they know we're a resource to help bridge some of that. Rachel.
For just a wonderful talk, and it's really inspiring set of activities. It's kind of a general question for the various biology trials, but I'm wondering to what extent the data that was collected it was sufficient, or how many of these trials can add additional data collections or learning around that?
Yeah, Rachel, it's a great question. So the question about burden of data collection, how much has been able to be collected in the process of care versus additional. I think for the most part, our primary outcomes, that is collected in the process of care. I think in all cases, we haven't had any that has been like specific to say experience as a for instance. Some of our secondary outcomes do require additional data collection, like we've had several where a survey is a part of the pragmatic trial, either of the provider, the clinician, or the patient, or all the above even. So there are some examples like that. And I will say, our reflection, as we've kind of gone through this, is we have found in all cases that having an implementation and sort of qualitative evaluation arm is worth its weight in gold. And I don't know if every place does that, but we have deliberately put that into all these evaluations, because knowing the why and what factors matter, we think that adds a richness that doesn't always come out. So. Yeah, Nora. Okay.
Merritt, who's a patient partner who is heavily involved in our P30 program. He was asking, so as he has been involved with the role that patients can play as a part of the training in the Michigan WellStar P30 program, he's wondering, what role do you think patient partners can play as mentors for all new LHS scientists? And how do you think generative AI can help patient partners to lessen the knowledge and power gap between scientists and patients with lived experience?
So the question is from online, a combination of what role can patient partners play with scholars that are coming in, as well as the role of generative AI with patients as a whole. I didn't emphasize it probably enough, but not all, but many, definitely anything that is being implemented, there's a patient aspect to it. And I will say some research projects that we do have patients throughout the entire cycle, like the example we gave with the patient safety learning lab. And then some, it's only at certain places. It's certainly a competency that we are building and making a part of our eStar training program. And I think that without that, it's missing the boat, right? If this doesn't serve patients at the end of the day, if the interventions that we're doing don't make sense and respect what patients want and need, it really is a loss and a missed opportunity. So absolutely advocate for that, and think it's, we've tried to very deliberately put that in place. And then the other question about generative AI, it's an amazing democracy element. Having the ability to have information at your fingertips, and I think about like how patients come, they have conversations with providers, clinicians, and you hear the statistics, right? The majority of the time, over half the information, patients don't remember after the fact. It's so hard to get in, the amount of friction to get in. So solutions that can engage directly with patients, it's happening already, and we need good solutions around specific questions or areas that patients can trust. So it's, you know, I'm a huge advocate, and I think it has to be done in, you know, responsibly and in a way that is going to not give misinformation, because we have all those other examples as well.
Like you talked about the traditional approach of kind of a project inception, and then there's a data management, which is
Yeah.
a long red one, and then you have the analysis.
Yeah.
And then you said your approach was where you know shrinking that red.
Trying.
So,
Trying.
so can you tell more about really who are the partners engaged in trying to do that, or what?
Yeah.
Is it
Yeah.
just providing more tools, developing more tools, and getting it into the hands of
Yeah.
policy analysts, or is it engaging with the IT team or the data concierges?
Yeah.
So you talked about that also to make that facilitators in the middle between the scholars and the analysis that they need to do.
Right. So the question was around data services, and, you know, how did that happen, and what is the approach to make that data more available? So I'll give you a couple of examples, but the overall approach has been that, well, we've had some investment in infrastructure. I will say that's number one. So I'll give you an example. The surgery department and the surgical chair said, we want data around surgery, and we want this built out really, really well. So we said, okay. And so we said, who wants to be engaged with this work? So we had a bunch of surgical clinicians like come and say, okay, you know, I want to know about, I don't know, surgical supplies. I want to know about my blood loss. I want to know about when the patient ambulated, and all these things. And so we have them available. We also have an embedded IT team that's embedded in the health system, as well as a data services team. And so all those folks come together to build out more variables. We have a terminologist that also works with us, which I think she's been really, really key. So that's the overall process. And we try to use their time well. And the reward that they get is they're a part of something that's going to be bigger. They can bring in folks from their division, their department, and it just is a really neat cycle. And so right now we're building out a lot of stuff in primary care. And it's been amazing, like who has come forward and just said, I'm willing to do this. So we have some funding for it, and folks are actually donating their time. It's pretty interesting. And I don't know if that happens in every place, but we've been surprised just saying, we are doing this. We'd love to engage you. We have had people consistently show up. Yeah. Mm-hmm.
Right. You have so much amazing work going on, and the conference is such a wonderful contribution to our field. It's really exciting to have an interdisciplinary group.
Thank you for coming.
And you started off with a 17-year papers. I think you're all aligned on your efficiency is a big kind of focus of, and you mentioned using time. And I wondered if you could share any thoughts here about should we be actually estimating efficiency or measurement maybe of doing that with the rapid evaluation? Are we speeding things up? Is that a priority for us?
So the question was around efficiency and how do we measure that? Should we measure it? And, you know, and should that be a key performance indicator? And how do we think about that more broadly for the field, for healthcare? So a couple side comments. I mean, I do think, you know, we talked about financial pressures that are going on. So that, you know, the word efficiency, whether it's speed, money, value, more money, more volume, you know, whatever I mean, that's real. And I think this idea of how do we create mutual value, mutual benefit, I feel like, you know, we've really dug deep into the quality piece, and we do probably need to even do more in the operational and efficiency piece, because honestly, that's, you know, no margin, no mission, and, you know, that's a huge issue. So just an overall comment about that. We are absolutely trying to, for different phases of projects, for each of the pieces. We're saying how long it takes, and we're being pretty transparent around it. Admittedly, there are some things that have not been rapid. So rapid eval. The first time we thought we could do it all. So the first round of rapid evals, we accepted 4. 2 of them were truly ones that were ready to go. 2 of them were not. The third one, ended up taking close to 1.5 years. The 4th one just got done 5 years later. But one comment there is, and I think I shared this earlier today, one of the best learnings, and we don't do it enough, is that deliberate reflection. So there's kind of an internal reflection we do in the center. So we just did this with this OPI trial, which, it was a great idea, but it had to be built. It had to be, it just goes on. It took a long time. And the resident is now a fellow. He's somewhere else. I mean, we had to figure somebody else out to get that through. But so we have an internal reflection. And for that same project, we did 2 different external reflections, one with the surgical teams and then another within IT. They had done so much. We had to push, our software developers to do things differently. They had to push the functionality for a whole bunch of different things. And I don't think that happens enough in partnership, especially with, the pointy-headed academics. There's so much appreciation after the fact. You can't measure that because the next time I need something in the patient portal around patient engagement, I can go talk to them. They're my partners in this work. So it's just a reflection that piece about talking about what worked, what didn't, thank you, does make a difference. Yes.
Wonderful to see the way you have linked so many groups that normally do not come together.
Yes.
The problem of our siloed groups is one of the tremendous contextual obstacles we all face.
Mm-hmm.
The part that I would appreciate you're preparing sometime in the future is I saw so many pieces. I don't see some of the underlying background infrastructure that holds it together. For example, it's the medical school, it's the health system and the school of public health. Someday when you want to put off doing other things, if you could doodle an organizational chart of the key groups and how they interrelate to have a background. And then there's a companion piece, the one I'm most interested in, is the funds flow model across all those groups.
Yeah.
As you talked about who was funding and how things together.
Yeah.
That's so key in the underlying infrastructure of who's willing to help.
Yeah.
That would really be fun to see. You've created a level of complexity in independent systems that is really fabulous. I'd love to see more about it.
I really appreciate that comment. For folks online, the great suggestion of, what does the underlying infrastructure, the different groups that have come together, and could we represent that, as well as things around funds flow and how folks have contributed in multiple ways to building something together. Yeah, I will say, I will try to take on that challenge, hopefully sooner rather than later. The funds flow piece is really interesting. We are not purely anything. We get some in-kind stuff from our health system partners. There is some in-kind. We're also really clear, if we're bringing something in that is more researchy, we need to do that in a way that keeps the health system whole. So I think that has been a factor in the success. And then, I think, there are pieces around extramural funding that have been very helpful, as well as obviously seed money And then the last piece that has, and then also departments, figuring out where there's shared value together. And then I think the last piece to mention that I don't think was covered anywhere is we function as an internal services organization and an external services organization, so we can get cost recovery around things that we do together. In some cases, that's a very useful model. So. But I like the challenge. Thank you.
So this is a question, somewhat along the same line than Erica just asked you.
Yep.
So we've seen and we've heard about it, and it's terrific, a lot of pieces. And let's suppose every one of those pieces, everything you described, is as successful as you hope it will be. How will people describe the University of Minnesota Medical School differently 5 years from now than they're describing it today?
So Chuck, that is like one of the exercises next week with Centricare. What's the headline in 5 years? So, yeah, so aspirationally, you know, I think the health and experience in the state of Minnesota will be fundamentally different. I mean, I think, and we would be able to point to where that is the case. And I would say at an infrastructure and process level, it is built into our health system partners in a very like tangible, ongoing way. And everybody knows about it and is buying into it, which is a tall order. Yeah. Ed.
About, people reach out to you, they're not building with different groups.
Mhm.
There's probably some groups that don't reach out.
Yeah.
There's areas
Yep.
in the medical center that aren't.
Yep.
It's completely voluntary. Is there any care or fit for any departments? Or
Yeah.
any groups to
Yeah.
be involved?
So the question was, you know, we found partners through various mechanisms. You know, there's probably some that don't reach out, and you know, how do we encourage it or mandate it or something along those lines? So currently, it's a very it's a little accretive, but I will say a couple pieces. We have made it as our one of our goals. This is last year and this year. It's around deliberate outreach. So, and we have focused primarily on what we called the Big Four for departments. So we started with surgery, medicine, peds, and lab medicine pathology is our next biggest. So that just happens to be our size wise, faculty wise, the biggest. And we have also now gone to peds and several of the other departments. We happen to have also, anesthesiologists. We go to the surgical chairs, so we get all the other surgeries outside of the main surgical department. Yeah, but it is voluntary. It does make a difference who the leader is in the group. So if the chair is very enthusiastic, I mean, we have, or division chief, I mean, that makes all the difference in the world. And, our chair of surgery, he has us come give an LHS minute at least once a quarter to tell folks, hey, come on, get engaged with this. And he put a lot of money in as well to build out infrastructure for surgery. So surgery gets special sort of services in some cases based off of that investment. We try to make that really clear. Yeah. Rachel.
That last question got me thinking about culture.
Yeah.
I was wondering if you're biased because you're in it, but have you seen a culture change? Do you feel that this messaging is getting down to the clinicians?
So Rachel asked about how does it get to the front line? Yeah, that's, what, that's always my question, because I'm constantly convinced that everyone fails at that. I don't care how often you like communicate. It could be like, we've been communicating this for months, like 20 different channels, like, and it never ceases to amaze me. Somebody walks in and like, I had no idea. I'm like, how could you not know? So I don't know. I don't have the answer because I am amazed sometimes how folks are extremely aware or how, folks that you think absolutely should know, don't know. So getting out there, talking about it, and also I think thinking about the language that you do talk about it. The way I talk about it when I'm presenting at a health system board meeting is a bit different than the way I might talk about it with clinical chairs versus at the University of Minnesota Board of Regents, or it's all slightly, and so understanding what's going to be most important to them. Yeah. Yes. Online question.
He asked, were those entrepreneurial innovations described in the talk serendipitous or planned as part of the census mission? And if so, how publishing findings for academic impact versus projecting them for commercial development?
Yeah. So the question was around some of the digital innovations, the industry partners that we've worked with, and how maybe it relates to the cycle, the work that we're doing, et cetera. So the digital technology work and the work that we do with industry partners has occurred in, I would say, like 3 or 4 ways. Some has been sort of happenstance. Somebody has come to us and said, I have this idea, I'm this far along, can we partner on it? So we've had those examples. We've also had examples where there have been grants where we needed, so for our interoperable decision support, we decided for that one, we were going to work with a vendor on that. And we worked out licensing so that if this were bought at other health systems, there would be a mutual benefit to folks. So there's multiple arrangements. We have not gone as deeply as I would have hoped at this point around development of solutions and commercialization. It's certainly an area that we are talking pretty actively about, but it just hasn't bubbled to the top at this point. So, and I'm happy to do a follow-up because I don't think I answered that fully. So.
We have time for one more question. There's one more question.
Yeah. Hi.
Speaking of plant culture, in terms of doing pragmatic trials in operations, and one of the tensions is you might find out something that they didn't want to know.
Yeah.
Experience in navigating that.
Yeah.
There are plans in place for when that happens, and
so the question was around the findings that you get with a pragmatic trial that maybe aren't what you expected. Maybe there's something negative that comes from it, and maybe our experiences with that. So we definitely have had some examples where the intervention we tried either didn't have an effect or maybe it was negative. In fact, we had one recently where we built this amazing decision support, we thought, and it behaved worse. This is right around C. diff testing. And, as it turns out, if you give people friction, which is what we learned from it, it doesn't make people do the right thing necessarily. So as an example, probably the biggest example where it became potentially more of an issue was when we evaluated our primary care transformation, which did not go, the results were not necessarily positive. And there was some back and forth with the health system to talk about how do we present these results. And we did end up publishing it and it was okay. And we did have to do some politicking and discussions around it. So it can happen. It can happen. And I think we've tried really hard to culturally have it be a safe place where things that don't work That's an okay thing. It's not necessarily a failure. And honestly, if it doesn't work,
Save money by not.
yeah, exactly. And we don't de-implement enough. So, one of the examples this time around is we are talking about, we're designing an intervention to de-implement glucose monitoring in the inpatient setting where it's not necessary, which is a great patient satisfier. It's going to save NST's time, but how do you design that and do that well? So, yeah.
Okay, thank you so much, Genevieve.
You're welcome. Thank you for having me.
I have a few announcements today, so if I can back, and I won't pin it on again, or we'll never get it off. I'm afraid. So, a few things, once again, about the CME credit for the program, for those of you who would like to pursue that option. Then, on March 11th, we are going to have a combined, and I didn't mention this when I talked about Leora Horwitz before, implementation science and learning health systems event that will begin in the morning and run through mid-afternoon. It's being sponsored by a variety of entities. You can register using this QR code if you have your phone handy and want to register now. Then on April 29th, moving ahead to preview the other events of this academic year's offerings in the Collaboratory. This thing's kind of mind, you set this to advance. Yes, you did. With 4 of our own learning health system luminaries, James Eckner from the Concussion Center, Joyce Lee from the Department of Pediatrics, Dr. Stephanie Taylor, who asked the last and best question of the group, and Alexandra Vinson, who is doing really interesting work with bipolar disorder improvement work, and Dr. Taylor is the hospitalist, very much supportive of learning health system activities. So now, then on May 14th, the cavalcade of superstars continues. Michael Sade, who is one of the leading proponents of patient engagement in learning health systems at Cincinnati Children's Hospital, which is one of the original academic centers where the idea of learning health systems developed, into a reality from an idea. So Michael will be here on May 14th, and I think that rounds out the activities for the year. Let me see if this thing, no, I'm gonna have to move it. Okay, so thank you. Thank you for coming. Genevieve will be sticking around for a few minutes after this presentation. So if you would like to have a word directly with her, she'll be down around the middle of the room, or maybe grabbing some lunch. But anyway, she'll be around. So feel free to come up and initiate a discussion with her. Thanks to everybody for coming in person. Thanks to those of you who attended online, and we had a really, really nice online attendance. Come in person for the food next time, and we'll see you on March 11th.